Hello, my name is Cynthia Prince, and I'd like to introduce my colleagues on Team 1, Jana Chavez, Neda Imam, and Theo Kinney. The problem we explored was predicting heart disease. Coronary artery disease is the leading cause of death in both men and women, and it accounts for hundreds of billions of dollars in excess healthcare costs every year. If we could improve doctors' abilities to predict which patients are at high risk of heart disease, we could increase efficiency, reduce costs, and improve health outcomes. Therefore, our team analyzed risk factors associated with narrowing of coronary vessels to predict a diagnosis of heart disease. We used the Cleveland Heart Disease dataset to test our hypotheses. This dataset consists of 303 observations or patients and 76 variables, although published experiments to date have used only 14. The patients in this database visited the Cleveland Clinic Hospital in May 1981 and September 1984, and importantly, none of them had a history or electrocardiogram evidence of a prior heart attack. Based on the medical research literature, we proposed 3 hypotheses. First, that 10 variables would be significant predictors of a diagnosis of heart disease. Second, that 3 variables would be significant predictors of high cholesterol, which narrows the coronary arteries. And third, that 3 variables would be significant predictors of high levels of fasting glucose, which can damage the heart and other organs. We will provide more information about these predictor variables in just a few minutes. The methodology that we used to test our hypotheses was as follows. For hypothesis 1, predicting heart disease, we ran a logistic regression using all 10 variables because the outcome variable of interest was categorical, either the absence or presence of heart disease. We then reran the regression using only the significant variables, and we split the data set into test and train samples to check the accuracy of our predictions. To test our second hypothesis, we ran a multiple linear regression because the outcome variable of interest was continuous. We then reran the regression using only the variables that were statistically significant. And we used the BIC best subset, the forward stepwise, and the backward stepwise selection methods to identify the best model. For our third hypothesis, which was predicting high fasting glucose, we ran another logistic regression using all of the variables because the outcome variable of interest was binary. It was either above or below a certain threshold. We then reran the regression using only the significant variables and created a classification decision tree, which we pruned to 6 nodes because at this point there was no further change in variance. Now to Neda for more details and findings for hypothesis 1.
Thank you, Cynthia. In this first scenario, we hypothesized that only 10 attributes are significant predictors of heart disease, which is measured by greater than 50% narrowing of coronary arteries described in this chart. However, after the application of logistic regression model on the described dataset, only 6 attributes were found to be significant predictors with p-value of less than 0.05. The reason for the difference in the hypothesis and logistic regression analysis for each attribute has been described in the next few slides. As per our hypothesis, male gender was a significant predictor. However, as per Cleveland dataset, both male and female genders are significantly associated with higher odds of male having coronary artery disease in comparison to females. This draws the same conclusion as that of our hypothesis. In the same scenario, we also hypothesized that typical chest pain is a significant predictor, while as per logistic regression analysis, asymptomatic patients are significantly associated. This difference in conclusion is due to the fact that patients don't develop chest pain until the coronary arteries are narrowed at 70% or more. Note that the cutoff value to predict heart disease in Cleveland dataset is 50% narrowing, indicating the patient population used in Cleveland heart disease dataset had coronary vessel narrowing between 50 to 69%, making them fall into the category of asymptomatic patients. In real world, there are different non-invasive techniques applied to assess heart disease in patient population, including the exercise stress test, cardiac fluoroscopy, etc. We also hypothesized that number of vessels colored by fluoroscopy using cardiac fluoroscopy technique is not a significant predictor. However, the analysis revealed the opposite result. This reason for the difference in conclusion is due to the poor accuracy of this test to predict heart disease, giving high number of false positives in the data set. We also hypothesized that EKG changes and exercise stress test method to assess the heart disease, including ST segment downsloping, horizontal sloping, and ST segment depression were significant, while as per a logistic regression model, only 3 slopes of ST segment, that is upsloping, horizontal, and downsloping, were the significant predictors. The difference in conclusion can be due to the fact that in real-life scenarios, the EKG changes with upsloping ST segments are ambiguous, which may mislead the dataset. We also hypothesized that exercise-induced angina during exercise stress test is highly predictable of heart disease, which is opposite to that what we found in our logistic regression analysis. Note that the exercise-induced angina occurs when there is 70% or greater narrowing of coronary arteries, but the cutoff value used in Cleveland dataset is again 50% narrowing of coronary arteries, indicating the majority of patient population used in the Cleveland dataset had narrowing of coronary arteries between 50 to 69%, making them an insignificant predictor. Now to Theo for further elaboration on these attributes.
Thank you, Netta. Another non-invasive technique we applied to predict heart disease in general population is via thallium stress scintigraphy. We predicted that reversible and fixed defect are significant predictors of heart disease, while as per logistic analysis, only reversible defect is a significant predictor. The difference in conclusion drawn is due to the fact that all patients selected in the Cleveland dataset had no history or EKG evidence of previous heart attack, which indicates the fixed defect on thallium test. We also hypothesized that increasing age is a significant predictor, while as per logistic regression analysis, age is not a significant predictor. The difference in conclusion is due to a small sample size with only 303 subjects. Similarly, we predicted that high cholesterol greater than 200 and fasting glucose greater than 120 is a significant predictor of heart disease, while as per our regression analysis, they are not. Again, the difference in conclusion is due to small sample size with less diversity of patients. We split this data in test and train and were able to determine the accuracy of this data set is about 61%. Hypothesis 2. We hypothesized that high cholesterol is associated with the following variables: increased age, gender, high fasting blood glucose. We used linear regression modeling with cholesterol as the dependent response variable, and using all other variables as independent, we find the following are significant: age and female gender. We find that although blood sugar is not significant, resting EKG showing left ventricular hypertrophy is significant. Fasting blood sugar was not significant, which may be due to small sample size used. Regarding the significant variables, females with older age are shown to have higher cholesterol. Age and female gender both have p-value less than 0.01. Resting EKG is less significant, although still significant with p-value less than 0.05. The adjusted R-squared using all variables is 7%. Removing insignificant variables from the model, we find that the adjusted R-squared does increase to 8%. Although this explains a small percentage of the variance, these variables were the most significant in predicting cholesterol. The forward stepwise selection also supports this, as the first 3 variables most contributable to adjusted R-squared are age, female gender, and resting EKG. Now on to John.
For our third hypothesis, we looked at significant factors for fasting blood glucose levels and the correlation to heart disease. Our predictions would be that increasing age, high resting blood pressure, and high cholesterol over 200 would be considered significant factors. Conclusion that we found was that age, high resting blood pressure, and the number of major blood vessels colored by fluoroscopy were the significant factors for heart disease. The major unexpected outcome based on regression models was that high cholesterol was greater than 200 was not revealed as one of the major significant factors for fasting blood glucose levels. Again, as noted, the small sample size and lack of diversity in the population sample could be one of the reasons for this outcome. The outcome that was not predicted, but based on the analysis, was that the number of major blood vessels colored by a fluoroscopy. Although our predictions were correct most of the time, there were some unexpected outcomes that came from the study. In order to adequately look at further predictions, sample sizes with incidence of myocardial infarction and abnormal ECG results should also be considered. Because these sizes were relatively small, this could have led to the outcomes we came up with. In addition, the use of fluoroscopy is considered inferior to the more standardized coronary angiogram. With the introduction of coronary angiography, that has changed the utilization of cath labs performing these types of procedures. It was also noted that some of the cutoff variables were inconsistent with what current literature recommends. Prime example being that patients may not experience symptoms of heart disease such as chest pain, narrowing of the vessels that reach 70% and not 50%. Thank you.